Okay, so I'm not speaking with you anymore.
Well, he picked you.
Oh, okay, for that part.
Well, yeah,
Okay. He picked me against his main instinct.
I know that. Big deal. The truth is he picked you.
Yeah, I agree. And he stayed out of my way.
Perfect.
I wouldn't say
Remind me, I'll tell you a John Clark story someday.
did you know him in medical school?
No.
Because it turns out Greg Sick says he was his tutor.
Good morning. Welcome to the first grand rounds of the season. It's wonderful to see everyone here, and I'd like to take a minute and introduce myself to you. I've been meeting some of you, but still have yet to meet others. I'm Sophia Vinogradov. I'm the new department chair, a new department head here of psychiatry, and I've been here all of 5 weeks and 3 days counting. And I've been learning a lot about the department. I've been enjoying myself quite a bit. I've been really kind of impressed by the knowledge, the energy, the new ideas, the enthusiasm, the expertise, the scientific expertise that is here in the department. And I think there is every reason to be looking forward to a really exciting year together. I just want to mention that on Friday, this Friday the 9th, I'm going to be giving kind of an inaugural talk, which will be sort of my thoughts at this point in time, after just 5 weeks here, about kind of where the department's been, where it is now, and where we can take it. So I really invite you to come and join me, kind of hear about some of my thoughts, which are in large part formed by some of the conversations I've been having with you, and also engage with me then in a dialogue after the talk. We'll have a reception here afterwards. I'm inviting also from outside of the department, friends of the department, people who have given money to the department philanthropically, people who are interested in the well-being of the department and the community. So I think it would be a nice chance to mingle among ourselves and among some of our community supporters. So please put that on your calendar. Today, for our very first grand rounds of the season, it's a real pleasure for me to introduce to you our speaker, Dr. Eduardo Colon, who even before I got here, I'd heard about as I was asking about kind of the overall teaching and academic and clinical practice landscape in the Twin Cities. Your name kept coming up as really just someone who had recently assumed a leadership role and was doing it with the thoughtfulness and graciousness and dedication that has characterized your whole career.
Thank you very much.
So I was very much looking forward to meeting you. We had a chance to chat a little this morning, and I'm looking forward to really continuing to work together. So Dr. Colon came as the chief of psychiatry at Hennepin County Medical Center how many months ago now?
January of this year.
January, so about
25 months ago.
Yeah. And he has been, of course, well known for his work at the County Medical Center throughout his career. And because of the long-standing history that Dr. Colon has had with our department as well as with the county system, we thought it would be great for him to come and tell us about kind of what's happening, what's new, and ways that we can be thinking about working together for our community. Dr. Colon is a renowned clinician in the field of consultation liaison psychiatry, and in fact, her name came up in another conversation about kind of the need for us to be thinking about our CL services here locally. And in fact, he's regarded as one of the most popular preceptors for our medical students in CL psychiatry. He received his undergraduate degree at St. John's University. He completed medical school at the University of Puerto Rico School of Medicine. He served his internship year at the Hennepin County Medical Center and completed his psychiatry residency and CL fellowship here in our department at the University of Minnesota. Dr. Colon is a full professor, and that's due to his substantial contributions to the literature, particularly the literature of CL psychiatry and most recently in the realm of the psychiatric aspects of diabetes. He also has an emphasis on healthcare in the Latino community, and in fact, he has successfully translated his academic interests into really direct service, the real translational component to which we all aspire in his role as vice chair of the Latino Diabetes Action Council. So Dr. Colon, we're very honored to have you here, kicking off our first grand rounds, and looking forward to really a very fruitful collaboration together.
Thank you very much. Thank you. Thank you. It's great to see many familiar faces, although I was saying earlier on, I'll use this one. I mean, no, I always have a big mouth. But many of my esteemed teachers, colleagues have retired, but there's still plenty of you left around. So it's great to come back. I usually make an appearance here about once a year. Dr. Buchanan, I always joke about she has the atheists from the county cross the river to talk about spirituality over at the university, and something I enjoy a lot. I think Dr. Buchanan is also retiring. Yeah. So it's a pleasure to be here. I think I personally have been looking forward to Dr. Vinogradov's arrival, being quite aware of the transitions, the difficulties, and the successes of the Department of Psychiatry at the university. And I think so has the community. So it was a pleasure to sit down today. One thing that I think most of you know is you don't have to worry much about being politically correct with me, because I ain't. And I think you have to be respectful but truthful about the problems that we all face. So I have two objectives, since I didn't have to write a long list of objectives. I promised somebody in my shop, number one, that I would not curse. I'm on a behavioral program, and it's working reasonably well with relapses. Actually, I had a resident who graduated about 5 years ago, and he thanked me for teaching him the power of therapeutic cursing, which I really believe is to be true. The second objective is that you'll walk out of here with no advancement of your intellectual knowledge. I was asked to talk to you about opportunities for collaboration and for rapprochement between our departments. This is a very important topic, certainly in my interviews for the position. It is something that our institution has been very invested in, and something that I personally also hold dear to my heart, having been through all the transitions, having been a part of the faculty for many years, and having fled or gone to Hennepin County Medical Center to follow Dr. Popkin for two primary reasons. One is because he was my mentor and my protector, and number two is because I had the incredible opportunity of creating a consultation service, which initially was a service of one person, took a toll on my aging, as you can tell, and has become a very productive department, I believe, section, with a very active teaching component, which has been the most exciting part. And I think actually Dr. Nelson was instrumental in kind of shaping the topic also for this conversation. So I thought, I don't want to stand here and talk about histories that are long gone or politics. I want to tell you a little bit about Hennepin County Medical Center, and I will highlight areas that I think are going to be very important for us to collaborate on. It's striking to me, even though I stay in touch with some of you, and I come here at least once a year, that I really lose track of what the components are of the department, what's happening, who is here, who's coming and going. And I think for many of you, Hennepin County Medical Center is across the river, and I was joking about the depth and width of the river, and somewhere down there where they do that thing and we take care of the population. And actually, we share a lot of the patients across the river, depending on where the ambulance goes and who brings them. So what I want to show you initially, I don't think it's here. This is a, excuse me. I'm going to go back a little bit. Just to remind you that when I was a resident back in 1932 or so, the University of Minnesota was described as a categorical residency program, which meant that you did your internship somewhere else, and then you joined the department if you completed your training successfully for the first year. So the two sites in Minnesota were St. Paul Ramsey, which became Regents Hospital, and Hennepin County Medical Center. And I happened to start my psychiatry career at Hennepin County Medical Center as an intern, where I did a little bit of psychiatry. I continued my relationship with Hennepin County Medical Center because I worked in what was then called the Crisis Center over an extended period of time. Throughout my whole residency, I was broke and I needed the money, and it was an incredible learning opportunity. This is what the department looked like to me when I joined in 1979. There were 32 beds in what was then referred to as, A8. There was the Crisis Center, and there was the beginnings of a mental health center. This is what the department looks like now. And clearly, I'm not going to walk you through every component. Excuse me, I do need to do some housekeeping as we speak. The inpatient beds, and I'll talk about some of these separate divisions. now has 102 beds. Our occupancy rate is somewhere around the 98%. And we have a more and more rapidly growing turnover, which from the financial standpoint is beneficial, but it also creates a number of other challenges. I'm not dying yet. So this is the flow among our different divisions in the Department of Psychiatry. The entry points for inpatient psychiatry, are the acute psychiatric services, which is really where we channel most of our emergencies. The consult service and the outpatient clinic. The acute psychiatric services are emergency room, and it provides 24-hour walk-in psychiatric intervention. I think we hear a lot now about the DEC and the function that you play in the DEC system. We have a suicide hotline. And we have a small group of patients who get seen until they make it to the clinic. Try not to do that very much. The inpatient service is 102 acute beds, which includes 21, intensive care beds. So over the last number of years, a number of interesting things have happened, not just because of the change in our census, but certainly the reintroduction of the psychology team into our group, which has led to a lot of focus on motivational interviewing, attention to the dual diagnosis. The other thing that I will highlight for you is that we have, I think Bill Miller was at the Academy meeting last year when we talked about this. We have developed a very close collaboration with our hospitalist intensive care internal medicine group. So now we have hospitalists based out of the inpatient psychiatry unit, and they provide very necessary care. More and more, we're treating more very complex medically ill patients. And prior to us doing this, there was a lot of travel back and forth to the intensive care unit and the medical floors, which is always not good for the patients and always politically painful. Okay. Outpatient clinic. We were talking a little bit about our outpatient clinic function. When we had our private group, Hennepin Faculty Associates, before we integrated with the hospital, our clinic basically was a service we provided for patients who were discharged and had no other access to other services. But the caveat was that they had to have some kind of public assistance because the faculty group, the physician group, was not getting a lot of the money for the pass-through. And the mental health center downtown served the function of the safety net for patients without any insurance. I was just talking about how our medication clinic has grown incredibly. We're out of room. I could not hire another provider until somebody commits to giving me another interview room. And the rooms are occupied 96% of the time. This is a discussion we had because throughout the administrative services, there's a push to try and change our scheduling structure and double book and do monitoring to see if the rooms are being utilized. A number of the other clinics have very low utilization rates. Not a problem. And I heard from some of your colleagues about the question of long-acting medications. Those are administered as part of our outpatient care. We have an LPN, we have a number of RNs, and patients come to our clinic and get their injectable medications on a regular basis. I don't have an injectable olanzapine clinic. I don't have either the room or the appetite for 2 to 3 hours of monitoring after administering a medication in terms of the structure. If you've ever been to our clinic, it's pretty cramped in there. And then we have a very active psychotherapy clinic. Both the role of groups has been growing steadily. We have a huge problem with our psychotherapy clinic right now, essentially no access. So we periodically have to close access to the hospital system. We've been close to the community for a long time, which in many ways is shameful. But we've been close to the hospital, and more recently we were even close to our medication clinic site. We're taking care of that problem. So we're in the process of, again, recruiting and hiring more psychologists and changing our structure. And that includes more attention to shorter-term interventions while acknowledging that some of our patients will need to be involved for a long time, and the utilization of other services. So since I started to talk about taking over the job, my biggest interest has not been in growing my department because it's about as big as we can handle it, has been in really stretching horizontally. There are so many resources throughout the county system that are not utilized, and frankly, that I don't know about. So our biggest challenge is to figure out who belongs where to get the services they need so that they can get somewhere close to their goals of recovery, not just graduating from a day treatment program and then going back to a situation where they're not engaged and they don't go back to the life they can participate in. There's a number of other outpatient programs. Without touching on many of them, we a number of months ago started our dialectical behavioral therapy intensive outpatient program. We've had a DBT track as part of day treatment for some time, but this was a new move over the last couple of months. And of course, like with every DBT program in town, they get full pretty soon, pretty quick. We have an open network and hopefully referring back and forth to the programs that have openings, including our own. We have a dual diagnosis track and day treatment, which is not a chemical dependency treatment program. It is really a supportive track in day treatment for people with dual disabilities, and that gets confused a lot. We have a very active partial hospitalization program. We recently increased the capacity to, I believe, I could be wrong, 12 patients. We used to be capped at 9. Our child and adolescent clinic, if any of you ever came to visit me, I'm still embedded there because I refuse to move. And the lobby is now totally crowded. Here's the problem. We don't have an inpatient child unit, and I don't have a vision right now of creating one, although I get a lot of pressure to think about it. And we all know that children are so underserved. The children are sitting in emergency rooms throughout the cities, waiting to be placed in an inpatient child program for which there's no room. And we have this problem because in our inpatient pediatric units, frequently we get referrals of kids in very incredibly complicated social settings, as you would guess, including recently we had a surge of young women being brought in who were in sex trafficking rings and nobody knew where to put them. So they end up in the peds unit. Some of these kids are quite behaviorally challenged. They have a lot of difficulties. And we have an active consultation service to them run by the child program, but it is not a mental health facility. They don't belong in our inpatient psych unit. I always tell them, come and walk with me to 08, and then you'll understand why I don't want to transfer a 13-year-old. Never mind programming and schooling and all the other things they need. Just physically, do you want a 13-year-old in my units? That usually stops the fight. But recently we had a young woman who literally was on a Versed drip in the ICU after repeated suicide attempts on a one-to-one in the inpatient peds program. And she sliced the bulb and cut her neck. And by the time we're trying to figure out what to do, George Riel Miedo at some point got involved and helped me to transfer her to the state facility, where she became a problem because she had broken her leg and she destroyed her wheelchair. And we've had child and adolescent units refuse to take some of these kids because they're too sick. To me, that is the biggest contradiction in the world. You cannot come in the hospital because you're too sick. If you're in restraint, screaming and hollering, you've been tased and given ketamine by the police in the emergency room, I would never say you can't come to psychiatry because you're too sick. Now, I will tell you that we have patients in our intensive care programs who we feel present too much of a threat to our staff, have been horribly assaultive, and we treat them intensively. And in the old days, these patients used to be transferred emergently to Security Hospital, which has stopped being a resource for all of us, including you, over some time. And we're all hopeful that the new commissioner will do something about this. And certainly transfers to Anoka, I will talk about briefly, but not to raise any concerns. We have a very active mother-baby day treatment program. There's only about 3 in the country, I believe. It's been very well received. For the finance people, it's been a nice program because it has mixed payers, which is very different from the rest of my clinics. So they like it. I like it because of the work that they do, and they do very good work. Dr. Helen Kim spearheads that, and she has been involved with the university in terms of a lot of the perinatal issues. And they just recently, last week, opened their intensive outpatient program, which we've been trying to get going for some time. People finish the day treatment program, and clearly, people are not done. Mental illness doesn't go away in 6 weeks. It doesn't disappear. And a lot of these people still need help, and they were not transitioned into our regular clinic. So we created the intensive outpatient program. I don't have any statistics to show you yet. And then lastly, the newest, but not really new kid on the block is something that Fairview has been doing for a long time, is the primary care behavioral health. Hennepin has decided to become a system, not a downtown clinic. So that means that they've been creating all kinds of satellite clinics throughout the community, some of which have been more successful than others. So we decided early on that since we cannot serve the needs of these clinics, I think we all struggle with this frustration. And you all know from the number of studies, including Don Rogier back when I was young, saying that 50 to 60% of our patients are treated in the primary care setting. And there's no doubt about it. Patients from primary care who get referred to my clinic, meaning our clinic, even if I have room for them, the fail rate was somewhere around 30 to 40%, which becomes a huge problem for outpatient programming. And more importantly, the patients keep popping into emergency rooms. High utilizers are not getting the help they need. So now we have mental health professionals throughout every primary care clinic. Initially started with psychologists who not only do short-term therapy, but also choose which patients need to come to the downtown campus for specialty care. And we now have 2 physicians who are going part-time to the clinics and 1 advanced provider who is also embedded in one of the clinics part-time. So everybody initially said, oh good, it will relieve the pressure from your clinic. And I said, that sounds delusional to me. Because essentially there's 2 things that are happening. We are trying to provide a service that we have defaulted on. We have failed to provide services to the primary care providers in our community, so we're trying to fix that gap. Number 2, you will identify patients who truly need to come to the specialty clinic, and we'll have to figure out how to do that. And yes, hopefully, we can manage better the patients who have mild to moderate illness, who can be managed in the primary care setting with supervision and support. Early on in this experience, we had a lot of problems with the internal medicine clinic, who have been our colleagues all along. Very thankful to them. But they really want the traditional model of having a psychiatrist co-located in the clinic. And you all know what happens with that. I'll set up a clinic for you in any of the clinics. Your schedule will be full in no time. You will never talk to anybody. You will eventually want to leave because you basically live in a closet in isolation. We need to have people embedded in the care unit that can walk in and out of rooms to help providers. And obviously the role of telemedicine in this will be greater as we go along, but believe me, I'm bumping into all kinds of institutional nightmares with the implementation of telemedicine, although there are a couple of pilot programs. So here are the volumes, just to give you a sense for how active we are. There's around 12,000 people who come through APS. These last 2 months, we've broken our records. So that is a big challenge in terms of not just physician staffing, but certainly in terms of the rest of the staffing. Because you imagine, ambulances are coming in with very agitated patients as well as people walking in. And we want to encourage people in crisis to come in, not just people hauled in by law enforcement. Our clinic is in pace to try to match up last year, which is banner year, but I will tell you that we've had a couple people who've moved out of town, so we're always trying to catch up to our full complement, which we haven't had in 5 years. This is the number of discharges from inpatient, about 2,600 last year. So far, this is from last month, 1,800. And the length of hospitalization has been a concern for administrators because it's always been very long. In our system, 14 days. And as of last month, we were down to 10.6 days. So I always like to say that's a good number financially, and none of us knows the sweet spot. What is the sweet spot when you're dealing with mixed populations with different problems, different diagnoses, and different needs? What is the adequate length of stay? The shorter, the better from a financial standpoint. At which point are we sending people out too soon? At which point is our discharge planning pretty, I'm on task, pretty crappy. So it's a challenge for all of us. So you track your readmission rate, but we have such an open system that readmission rates don't always really reflect what's happening to our patients in the community. Obviously, we don't like to see people come back. And certainly, if you have patients with Medicare, you don't want people to come back because they will not pay you. So our readmission rate has gone, in spite of our shortened length of stay, from 14% to 12%. And that gives me some sense of relief. And I will tell you what I say to my administrators: the only way in which you can responsibly and clinically do a good job and reduce the length of stay is if we can get people connected to resources in the community and to outpatient programs that will help them with their recovery, because hospitalizations don't lead to recovery. Hospitalizations lead to acute reduction in psychiatric symptoms, and then we wave people out the door and good luck. I can't find my way through the maze, and somehow my chronic and persistent mentally ill patients will navigate the county system with no problem. Good luck. So these are the challenges we faced, and I'm sure I tend to blab a lot, so I better pay attention to time, that these are similar to the challenges that you faced. One of the things I've discovered over the last 2 years, belonging to a couple of leadership groups, including one put on by the Minnesota Hospital Association, is that we all share the same anxieties, troubles, and sometimes patients. In the old days, there were the academic institutions, the public institutions, and the private world, and everybody had a different agenda. And I think right now we may have different agendas, but I think the problems that we face are very similar. We're at full capacity. Every morning I get a series of reports. We do electronic huddles, so this damn thing is buzzing the whole morning. At capacity, 4 people waiting in APS, 4 people waiting in the medical units. There was a period of time a few months ago where I had people sitting on the medicine floor for 10 to 12 days waiting for an inpatient psych bed. I was the vice chief of psychiatry at that point. Now I'm the chief, and I'm having fits about we need to get these people over. However, when you have somebody who's acutely psychotic and restrains getting emergency force medications in the emergency room, they take precedence. So I encourage my patients on the medicine floors to act out so they can get moved. I'm kidding. I don't do that. Would never do that. The other problem is that we're all facing more and more patients with complex medical needs. We've created an epidemic of diabetes in our population. We have created a sedentary lifestyle. We have failed to keep our patients from smoking. So all of our aging patients, and I include people of my age, are faced with a huge challenge. Everybody in this audience knows that our patients die on the average 10 years younger than age-matched groups. That's not a mystery anymore. And yet the question becomes, what do we do to prevent it? More importantly, acutely, how do we take care of those patients? Which psych units are willing to take patients with horrible medical problems? And my fights with our triage nurses were wonderful, really have become a lot less and less complicated since we've had internal medicine work closely with us. If there's a problem or concern, I get the internist or the hospitalist to come and see the patient and decide at which point they can manage them, and they follow them very acutely. What they do every morning is relatively simple. They look at the list and they designated category 1, whatever they call it, are people who need to be seen every day by the medical team. Category 2 are people who should be seen at least once or twice a week. Category 3 is you need not bother unless or until they call you. A number of transfers to the intensive care unit has dropped dramatically, still happens, and certainly the number of arrests in the unit has gone down significantly. It's not pretty to have a cardiac or a respiratory arrest in the psych unit. If you've been to our hospital, nobody can figure out how the hell, I blew it, how the heck to get up to 08. So we've decided plans to have staff parked along the hallway, kind of going this way, this way. It works. And then the other things we've tried to do is we have one of our cardiologists very interested in our patients, and we kept harassing them about QTCs and all of the problems. And he now goes to day treatment and sees some of our patients, and we can access him for consults. And we have one of our primary care docs who's part of the inpatient group, who actually, Ellen Coffey, who I think you've met at the Academy meetings, Bill, goes to day treatment once a week to see patients, kind of open-ended. She opens the door and people come in, and I need to make sure that she's utilized because pretty soon somebody will pull her if she's not seeing enough patients. Actually, my latest interest is in seeing whether I can have patients from my clinic go to see her, because it's either you send people to the emergency room, which is problematic, as you know, or you tell them go see your primary care doctor, which doesn't happen. So I had a patient, 3 weeks ago? 3 weeks ago or more. A young lady I've been treating for a long time. She now has diabetes. She's on clozapine. She has a history of seizures, and she was very hypotensive. She was drowsy. She did not look like herself, and we checked some orthostatics, and she was dropping her systolic blood pressure by about 30 points and symptomatic. She also has Parkinson's, by the way. And everybody's saying, oh, change her meds. She's acting out. Well, I'm not going to drop her meds, increase her meds when she's orthostatic and about to fall on her head. And I actually want to reduce her meds because I'm worried. Is this her Parkinson's or diabetes or my meds? So I sent her to the emergency room with due diligence, tried to call over and get a hold of somebody, and left a message and wrote a quick note in Epic about what's going on. She was admitted to the observation unit. The next day I look at the entry note, patient from the psych clinic, followed her closely. The note essentially made it sound like I overreacted. There was some concern about a chronic problem with blood pressure. It was not a chronic problem. But we all know, I will tell you, anytime anything happens to me, take me to my emergency room. This is an incredible place. So I'm not being critical of the emergency room. But the reason why a lot of patients don't get good medical care is the minute you have a psychiatric label in the chart, everything is psych. You know, somebody comes in with altered mental status, it's her bipolar acting up. And God knows that every patient I see in the medicine unit says that they have bipolar affective disorder, substance use disorder, schizophrenia, schizoaffective disorder, and sometimes anxiety and panic, which justifies this annex. So there's the issue of the stigma that I think as a group we've all been aware of, and many of us don't do as much as we should do. Certainly there's the fear of our patients who don't come to emergency rooms and say, hey doc, I've been having chest pain when I walked half a block and I've been sleeping with 3 pillows, and I actually need to puff a albuterol once in a while. Our patients don't, many of my patients don't say that. And lastly, we have a large geriatric population with a lot of challenging behavioral needs. And I tell my residents that aside, they start to notice my cognitive decline, which is palpable, at some point they should decide to do a lobotomy on me. Because if I'm not a pleasant patient in the nursing home, they won't want me. And I have a feeling I'm going to be cranking or in a problem. And of course, I don't want them to touch my brain, but that's a metaphor. Patients with dementia of whatever kind act out in the nursing home, they don't want them back. They don't want them back. I understand that if my grandma is sitting in that nursing home and there is a psychotic patient who's making noise or may barge in, that I would not want that patient there. I'm trying to think like a regular person. But where do these people go? If a geriatric or a memory unit cannot take somebody because they're too demented, this is kind of like a child who can go to an acute child unit because they're too sick. I thought that's what a memory unit was supposed to do, is deal with behavioral complications of a dementing illness. They don't have the resources. To be honest, they don't have enough staff. They don't have the training, and they don't get paid enough for what it takes to staff up. So last year we introduced, with the help of our lobbyists, the bill to the legislature to try and have some pilot projects where you could partner with a nursing home, anybody in the state, this wasn't about us, to see if they could be paid a higher rate, whether they could open up one of the many closed units to provide care for a small group of patients with behavioral and medical needs. Didn't get very far. I'm sure it'll keep popping up. Remember, there used to be a place called Agua Ching. You're probably all too young to remember Agua Ching. It was a nursing home somewhere up north. I never went there. It's some idyllic center. Bill lives up there somewhere. That took all the patients with dementia, medical problems, who had psychiatric problems. That place was closed down when there was the interest in deinstitutionalizing. Those patients haven't gone away. And these are not patients that any of us feel we can discharge to a shelter. And these are patients who, when they're in my unit, might sit there for 3 to 4 months. An acute unit that's not intended for long-term, that doesn't allow people to go out very often, and frequently you need to beg, deal, I'll take this one if you take that one, to get the patients placed. And then lastly, we've all struggled with the access to state-operated services. Anoka is full, and Anoka has struggled. And I feel badly for the people who work at Anoka, but hopefully the new commissioner is she's very invested in trying to fix this problem. And lastly, we closed the state hospitals because we promised that we would give resources to support these patients in a better environment in the community. That's what it was intended to do. But we never spent the money or created the services. And the ones that we created are so disjointed in terms of access that we really have not met our promise as a state, as a country. This is not a problem just here. And I can sit there and whine about it and always ask myself, and what have I done about it? That's a tougher question. In my next iteration, I'll be no. So this is where my patients go. I was surprised a couple years ago to see similar numbers. 66% go home or to a family home. 18% go to mental health facilities, group homes, IRTSs, and you know that access to IRTSs has become a problem also. We've opened up, Hennepin County opened one, and they now have money on the table to open a second one. Many places have IRTSs that are being operated at half the capacity because they cannot hire enough people. And more importantly, the idea of creating IRTSs does not take into account the fact that many of these patients need intensive care and have a lot of safety needs. So you create an IRTS somewhere because it's politically favorable. And also, a patient goes there and they are behaviorally dysregulated. The sheriff has to come in from the town. So you're not going to want people who need that level of care, and we're back to the same cycle. 6% of people go to chemical dependency treatment. That probably underrepresents the people who should go to chemical dependency treatment by at least 75%. And this is now a huge problem. The state has closed down a couple of the care units. There's not enough places. And frankly, we need to think broadly about what we're doing with chemical dependency. We take people and put them through 28 days in a program if we're lucky, and we get them in. They get discharged with no resources. They go back to the same neighborhood. They walk by the crack house, and they're back in the emergency when I want to kill them because they're using. What do people need, and what support do we have as a state for it? This is the land of 10,000 treatments, and our problem is still quite large. Fairview has the lodging program, which has been a place that we can't access frequently, but when we do, we're very grateful for. And then 13% are committed. And that's a problem, but I will not belabor the point. State-related problems, I will not belabor the point. I'm talking too much. This is our admissions to Anoka State Hospital over a number of years. Anoka Metro Regional Treatment Center, I should say. It was Anoka State Hospital when I worked there for a couple of years. In 2015, we transferred 5 people to Anoka. We had waiting lists. Every day we talked about the waiting list, and we spent all of our agonizing time trying to figure out how to leverage the state to move somebody to Anoka. The Anoka story is long. You've read it in the papers and you've lived it. Between the reduction in beds, there were 300 and some beds when I worked there, and there are now, I think, 105 operational beds. They've had to import everybody from the 48-hour rule from the jail facilities, and they've also become a competency restoration site, which it was never intended to be. So the commissioner has a lot of work ahead of her, and I think she's focusing on Anoka and Security Hospital, because they are really a problem for all of us, not just for the state. And then the community problems that you all know. This is what I've been whining about, because this is close and dear to my heart. If you have a trach, if you have a feeding tube or a gastrostomy, good luck. And if you punch somebody, I had a patient, by the way, who, yes, 5 minutes. Oh my God, I better run quick. I had a brief moment early on, so I apologize about the delays. We're a big center for education. When you talk to physicians throughout the state, a huge percentage of them said they've trained in some way or another at Hennepin County Medical Center. That's a source of a lot of pride for the institution, and something that the rest of us do not want to lose in the wake of all the financial pressures to be more streamlined, to be more efficient. We teach medical students, psychiatry residents, nursing programs. We have psychologists who come every year as fellows, child fellows, and regular psychologists. And we also have rotations for physician assistants. And more about the medical students, we have, last year we had 56 students in 8 rotations. I have a 1-month clerkship that's usually filled for somebody, usually somebody who's interested in psychiatry who wants to come and spend a month. It's nice to have a student for a longer period of time and really see them work rather than just bouncing around like they do in the other rotation. And people have arranged for individual rotations for students, both in the jail, ECT, the high-risk OB, mother, baby, and outpatient. A little more challenging, but we get it done at times. And this is about the residency program. The residency program has grown over a number of years. And we lose a lot of residents at the end of third year because they go on to do fellowships, oftentimes child fellowships. And many of them have come here. There's a list of places where they have gone. I am always proud to say that more than half of our residents stay in the Twin Cities, since we have such a shortage of psychiatrists, and 75% practice in Minnesota or nearby Wisconsin. So I think that's a pretty darn good retention rate, but we need more. We all know that there's no surplus of psychiatrists in town. So our relationships with the university, obviously, medical students, this has been a part of our DNA since I remember, and I was there as a resident of the University of Minnesota participating there. So opportunities for collaboration. We've talked a little bit. Wouldn't it be nice, thinking ahead in a couple of years, and I know Dr. Nelson has had a lot of very important and good discussions with Dr. Oakman. Couldn't we exchange rotations? Couldn't we share share resources like the psychotherapy course? The Psychoanalytic Foundation only has so many people to teach. And why are we splitting them up, or we're splitting them up? They're joint now, right? Did they sit in the same room? Yeah. The residents from your program and mine?
No, they never have.
Well, they should, and that's the point. It's like the same speaker going to 2 sites. This is the year 2016. I have residents over at Regents and I have residents at Hennepin, and we communicate via telemedicine. Not as well as having them there so I can catch them when they fall asleep, but it still works in a pinch. We have fellows from the university and the child clinic. To me, this is a quantum leap, because you have no idea how much bureaucratic crap we've had to deal with about arranging for somebody to cross across systems in terms of payment and reimbursement and that kind of stuff. So we love having fellows in our child clinic. And lastly, we teach residents. We have a lot of similar needs in terms of curriculum. We're talking about, what's the name of the exam that I can never remember?
Right.
No, the interview.
Clinical skills.
Clinical skills, that's what it is. Why don't our residents get examined by your staff and yours by mine? Because the river's deep. and it makes no sense. We tried to do this with Mayo. The road is long, and that didn't work very well, but it makes perfect sense to me. And there's not a lot of marble over at Hennepin County Medical Center. And then lastly, the exchange of expertise. Dr. Lim came over and gave grand rounds about 3 weeks ago. I think this is the first time I've had a speaker from the university in a long time. And I hope it's the beginning of something important. I don't have a huge budget for lectures. I'm sure you don't either for grand rounds. They're frequently residents fulfilling their needs. And it was great to hear about his research. It's certainly intellectually stimulating for me. And more importantly, if you have your staff coming to my place, you're no longer a stranger. There's nothing more isolating than not knowing who them is. You know, it's always those people, that place, the university, the Abbott, and if you don't know the people personally, it's very hard to think of collaborating and being close together. So we need to show our face over here more, and you need to show yours. Works both ways. Research, I will tell you that in an environment where we built a department that has been fiscally responsible and driven by meeting our fiscal needs, I'm being perfectly honest. Our research endeavor has dwindled, not as a hospital, but certainly as our department. Our department is probably one of the departments that's that is solvent at Hennepin County Medical Center right now, even though we're going through a huge financial crisis. It's taken a lot of work, and we have to do a lot of work to not wreck the teaching of the residents and the students in the context of making people be productive. It can be done, and I think it's worked. Carlos Schenk and the Sleep Lab were a big center of excellence for research. Dr. Schenk described the REM sleep behavior disorder. It's called the Schenk syndrome in Germany, and together they published an incredible number of publications, and lately that is not. We have a lot of scholarly activity, and our psychology fellows have a list of accomplishments that you cannot believe. So one of my missions is to try and recruit, and I'm in the process of trying to recruit a white paper researcher jointly with the medicine department. There's already somebody working on diabetes, mental health issues, and we'll hopefully get this done once we breathe from the financial crisis in the next couple of years. Collaborations with addiction medicine. Unfortunately, everybody wants my patients, and that's a problem. The tobacco group wants to do research with our patient. Addiction medicine wants to come to our clinic. So in all frankness, in terms of rebuilding our relationship, what my faculty bristles at the most is the perception or fear that the university sees Hennepin County at times as a farm for research subjects. And that will not work, and it hasn't worked. So this is what we need to work on, is being able to involve people across the river, know what we're all doing, build working academic relationships, and ultimately, hopefully, participating jointly in following the patients that we share in common. We're just opening our first psychosis episode program. So will you. What a great moment to try and establish some contact and relationships so that we not only have shared metrics, perhaps, so you can pool data, shared resources, conferences, and ways of really building a relationship that includes colleagues, not just people from there or from here. You used to have a first episode psychosis program, it's no longer here. Hennepin and the University of Minnesota have been lucky to get the grants from DHS to do this, and I'm very excited about this because this is seminal in terms of where we're going with psychiatry in general. A lot of the things that we do for first episode psychosis, we should translate into things we do for other people, and having your new chief here will bring a nice wave of interest in cognitive function in our patients that has been so neglected. Instead, we get caught on every drug company now will have a cognitive metric that says they work better. That's not what I'm interested in. Remember the negative symptom metrics? Oh, the new drug treats negative symptoms. Katie comes along and it's like it's the same. It's good marketing. Anyway, there's no reason why we shouldn't be closer. And I really trust and look forward to a time when we do. I come over here, nobody assaults me. I hide, but that's a different story. I go to some rooms where I have a little bit of PTSD, but that's not true. So I am so grateful and honored to be here and share some of this with you. I hope we don't become strangers to you as we have in the past. and vice versa. And I'm so thankful for the invitation from both of you. And I'm sure we're going to be having a lot of dialogues along. Thank you very much. Get out of here. It's 12.
Before we get kicked out, is there any questions about anyone would like to ask? Thank you for that impressive presentation.
Well, thank you very much.
It's really inspiring to see what your department has been able to accomplish. I would say my question is, if you were to identify the one thing that you would like to see from the department here, say in the next year, what would it be?
I think it has to be around education. Mm-hmm. I think it has to be around our residency program and around more joint ventures. Yep. That's the easiest, most accessible, and most reasonable.
Low-hanging fruit.
I think so.
Yeah.
I think so. And I know Cass will resist greatly. Yeah. That's been your history, right?
Yeah. Great. All right.
Yes?
I have a question. What do you think is the solution for the logjam of psychiatric beds? Is it the state supporting something short of a state hospital, long-term care, but smaller units?
Luckily, Chris Harris is not around. Chris is one of the Star Tribune reporters who's been talking about this for some time. If I had the answer to that, I'd be running for commissioner. So I'll share some thoughts about what happens. I think, first of all, we need to have access to longer-term beds. Regardless of what you do with the institutionalization, there is a large number of patients who will require longer hospitalizations. Even if you have the right resources in town, compliance, adherence, and the nature of the illness is such. And then you add substance use. So we're going to have, we always have had a need for longer-term beds. The longer-term beds at Anoka have become used for something other than that. And I think we need to make sure that the beds at Anoka Metro Regional Center or whatever treatment center are really preserved for the people who need that. We need to have enough dual diagnosis, true treatment programs, not just places who say, we'll give you your meds and we're a dual disability program. We need to really address the chemical dependency problem, which is killing our population. I think those two things. The third is the obvious. Sue Abderholden would say we need more resources in the community. We're about to open a 16-bed transitional crisis home on Chicago Avenue. Will that fix our problems? Yeah, I hope so. So people who end up getting hospitalized because you can't find anything else to do, there may be resources in the community, like we have one transitional crisis home in town that's always full. Regions, Ramsey has 2 or 3. We only have 1, and now we'll have 2 and hopefully 3 because the county will be opening a 3rd one. So my thought is patients who are sitting in our unit waiting for a CD bed, waiting for placement, who are really done with inpatient hospitalization, they just need to transition, are better off being supported in that environment than taking up an acute inpatient bed. So I think if you do those 3 things, the problem is a lot better, not fixed. Yes?
Yeah, and so I used to work at Nancy Page, so I know this issue. How long are you planning to be able to keep people at this new crisis transitional home? Because unfortunately, sometimes if you have to wait more than 7 days to get into a treatment program, then that's too long for
Is this being recorded? Yes. No. So 14 days. Now, the discussions we've had with the county board, with the people in the community has been, that's the ideal. We understand that there will be some people who may need to be a little longer, as long as there are things in motion. You're not going to have somebody stay in a transitional care home if they're just sitting there, drinking coffee, and not talking to the social workers and not getting plugged in. So as long as there's something active, I have no plan of having the program fire people. But frankly, we haven't opened our doors yet, so I'm sure I'm going to have a big blast of reality in the next few months. But you're right, 7 days is not enough. Nothing happens in 7 days. I just came here almost late because there's somebody who's using cocaine every day, has been in APS 4 times in the last month, and they want me to take him into inpatient psychiatry. Doesn't have one psychotic symptom right now. He's a patient with chronic schizophrenia who's been off his meds. And the answer is we don't have somewhere to have him stay until he goes into CD treatment, if he agrees to go to CD treatment after he detoxifies. So some of the hospitals in the outlying areas have said to me, even in the Twin Cities, that they admit intoxicated people to detox them because their emergency room will not do it. Now, there's a shortage of psych beds, and this is what we're doing in an inpatient psychiatric bed. That's wrong. It's wrong. It's not because I don't care about people who are going through detox. I care about them a lot. But there's a psychotic patient downstairs who needs to come in, and there should be a research for treating the people who are going through withdrawal in a more humane way. I'm getting old, but I'm still idealistic once in a while.
Thank you very much.
Thank you.